This is
Hello.
Dr. Bailey.
Hello.
He's in residency in Las Vegas, and he's a recent, well, I don't know recent, but 3 years ago graduate from here. So he's offered to answer questions we have, tell us about his residency program, and pretty much just kind of tell us what life's like on the other side. So let him take it from here.
Oh, can you guys hear me okay at this volume?
Yep. Yes.
Okay, great. Well, thanks for talking to me today. She said I graduated from Paul Foster in 2013. Yeah, I was the first first graduating class, I guess, coming out of there. So it seems like yesterday. I'm in Vegas, residency in Vegas. Just a 3-year residency, just a busy county program, a lot of sick people and a lot of trauma. It went by fast so far. I feel like I was just at Paul Foster. I miss it a little bit. It's a great school. They're preparing you well, trust me. Guys, so we'll just start off by letting you guys ask questions about residency, why I chose EM, anything you want. It's very informal. Tell you what, let's start with why I chose EM. How about that? You guys keep eating. So, at the end of the day, my background was in nursing. I did ICU nursing for almost 10 years before med school. A lot of that was in the military. I'm still in the military, in the Air Force. So I thought in residency I'd find this quote-unquote perfect fit of something that I 100% knew that I was made to do. And I figured out halfway through third year, well, that really doesn't exist for most people. So can you find something that you think you're 95% a fit for? So for me, I knew I wanted something. So I always tell people to ask themselves, do you want to operate or not? And break it down into, okay, I do not have to live in the OR, so take surgical stuff out of it. For me, I didn't want to do clinic type work. I wanted to work and be done with work. I wanted to do something crazy procedural, a lot of procedures, and just do something with a really wide scope of practice. And at the end of the day, that was sort of like, well, okay, that's ER. I was anesthesia for a long time. And at the last minute, kind of decided, you know what, I just want to be more versed in a lot of different things. So I decided, you know what, at the end of the day, it was ER, and so I chose ER. Kind of based on all that, for me, it was just what scope of practice that I want. And it was a good fit for me. It was very procedural. It's shift work. You know, when I'm done with work, I'm done. I don't go to clinic. I don't carry a pager. That's it. You're done. And in EM, you learn to pretty much talk about everything in medicine. I mean, it doesn't matter. You do everything. What they call us the masters or jack of all trades, masters of none kind of thing. We sort of laugh at that once you're on this end of it because you know a lot about a lot of things. But that's why I chose EM. I just had to kind of pick something that I thought fit everything that I wanted.
How do you deal with, I guess, like no follow-up? Because I'm struggling like with that. Because I like ER, but I don't know if I like the disconnect.
Well, let's see. A lot of us in EM are okay with no follow-up. Well, I see what you're saying. Yeah, you get these patients all the time. They're interesting, and you're admitting them or discharging them. Okay, what happened? You know, what happened then? I think. So what you do, and what most of us do, is we keep a log. We keep a sticker log of all of our patients that we see. And it's kind of on us to go back and sort of track them down if we admitted them and see what happened. And really, if you admit them to the hospital, you need to track them down and read about their course. That's how you learn kind of what happened and how to manage certain things. If you discharge them, you discharge them. And honestly, if you really want continuity of care and that's important to you, I would question you. Think about maybe internal medicine or even family. Because you're not going to have really continuity, right? You're going to need your bounce back patients and your patients that routinely use the ER as their primary care, which they do all the time. But yeah, I see what you're saying. If it's something you're really passionate about, though, just think about how passionate you are about it, and then, can you live with no continuity of care?
Is there something that you did or wish you had done during medical school to help prepare you or make you more competitive for residency?
Oh man. Yeah, stayed in medical school for another year. Not really. I think it's one of those things, and you guys are in med school now, so you get it. You know how when you're trying to get into med school, you're trying to do everything you can to prepare yourself more for med school. But tell me if you agree. Once you're in med school, you realize, man, yeah, there was nothing else I could have done because this is kind of hard and overwhelming anyway. It's kind of the same going into reg. Be prepared well, whether you realize it or not, as best you can. If you know you want to do E&M, obviously, yeah, start, shadowing, try to maybe get into an EM research project, get in the EM community. And as you're approaching third and fourth year, sure, make sure you're, a rock star at your ACLS, your PALS, your resuscitation, your kind of bread and butter emergency medicine stuff. But other than that, no, just stay focused on learning all your core competencies. And if you want to do EM, it's like we see pediatric patients, OB/GYN patients, psych patients, septic patients, shock patients, crashing patients, lacerations, trauma. You see every off those. So kind of pay attention in every rotation. Take in all you can. You will see every kind of pathology there is coming through the ER. You're the gateway to the hospital. But just get around it. Just get around the EM community as much as you can just to make sure that it's a good fit for you.
What's a week in residency like?
A week? Well, it depends on which month I'm on. I'm in the ER right now, so if it's an EM month, it's shift work. We do 12-hour shifts. Sometimes turns into 13-hour shifts. It just depends, or more. When our ER is very busy, it's nonstop and it's very busy. So when we work, we work. It's pretty hard when we're there. We see a lot of patients. You're pretty exhausted. Your days off, though, it's great. Your days off, you're off. So we do what? 18 shifts a month, basically, as an intern, and 17 as a second year. I do one less as a third year because I'm the med student education coordinator here as well, so I do all their schedule, do lectures for med students. Now, if you're on an ICU month, that's the hardest month, right? That's 6 to 7 days a week, 12 hours plus per day, 80-ish hours on paper anyway. It usually ends up being 80 hours. A trauma month for us, where you're on trauma service or trauma ICU month, you kind of live at the hospital those months. You just kind of learn to put your head down and grin and bear it. So those months, you come to work and you go home and you stay at the hospital most of the time. But it really just depends. In the ER residencies, you rotate through so many different kind of areas. But all in all, it's not bad. I'm friends with obviously surgical residents, plastic surgery residents, and their life is much more difficult in terms of work ethic. But it depends on the month. It honestly depends on the month. It's very manageable, I'll tell you that. Yeah, I'm not crazy overtly stressed out all the time.
So, you know how ER work is very procedural, or it can be procedural? Was there anything that you were surprised about that they expected you to know how to do going in?
Well, it may be just specific to my residency, but here, as an intern, the sick kind of crashing patient, that's your patient, even on day one. Some programs sort of graduate residents to the sicker, more unstable patients, more so for the second or third years. Our program flips it, so my first shift here, as a resident, as an intern, I had 3 ICU admissions, 2 intubations, 2 central lines, and I literally shifted. What did I get myself into? This is insane. They basically just expect you to be able to not go in and manage that perfectly, obviously, but early on they want you seeing the really sick patients, and they do that to get your comfort level to a level that now I'm very appreciative of that they did that to me, even though it almost gave me an ulcer that year. No, honestly, they expect you just to start, with the basic things, being able to take a good HPI, figuring out why we're really there, and really in ER, it's getting to form a gestalt on, does the patient have something serious, or are they sick? And they want you to build that, but it takes time. It takes, a long time to build that sort of kind of sixth sense on, we've seen so many patients per shift. But that's what they focus on here, is just learning to manage really sick patients early on, and then kind of learning how to focus on why they're there, what you need to do. And our mantra is you need a disposition as soon as you walk out of the room, right? They want you to walk out of the room and know, okay, admit, go home, consult, kind of have a plan, because they can't sit around all day there. So that's what they push here. Other than that, I mean, I think it's the same anywhere else as far as they expect you to become good procedurally because you have to. But I think in the mantra and ER side, I mean, you really have to, you're all the time trying to turn beds to get to the sick patient. And that's where a lot of people think they want to do ER, but then they go in and we see rotating students all the time. They want to do these kind of huge inpatient workups in the ER, and that's not going to work, right? That's going to tie up a bed where somebody's sitting now in the waiting room with a heart attack or a AAA getting ready to burst. That patient, you got to identify and get it back. Does that kind of answer it?
Yes.
Yeah. And not to try to scare you about our program, I'm so thankful that they do it like that here, because now zero problem managing, multiple kind of crashing patients. Those are easier. They're simple as far as what we do. It's the weird stuff that's kind of trying to figure out how to deal with now.
As a third-year resident, are you interested in any fellowships such as like ultrasound or PEDS or anything like that? Do you think they're very beneficial?
I almost did an ultrasound fellowship. I really am interested in ultrasound. I like it a lot. We do it a lot here. It's really pushed. I will tell you, if you do not like ultrasound, don't go into emergency medicine. Because it's part of our scope of practice now. We use it a lot, every shift. I almost did apply for a fellowship. I just decided at this point, I'm kind of tired. I worked for a long time before med school, and now med school and residency, I'm just sort of ready to be done. But toxicology, PEDS, ultrasound, that's kind of our big ones. You can do research, you can do international medicine, disaster medicine. Some places even do tactical medicine where you're sort of working with police and SWAT. That's very unique to EM. In Vegas, we coined the term, it's not a fellowship here, but event medicine, because our residency works with all the big events in Vegas, like NASCAR, the marathon. I don't know if you guys have ever heard of like Burning Man or the Daisy Carnival. So we man that. We have medical tents, and that's insane, the stuff that you see and do. But yeah, there's lots of fellowship opportunities. If I had to do critical care, so if I had to do one, I would either do critical care or ultrasound just because that's my interest. But plenty of opportunities.
Thank you.
Why did you pick your program?
Oh, why did I pick this program? Was that the question?
Yes. Yes.
Basically, I rotated here as a med student. I actually thought I would want to go back to San Antonio. That's where the Air Force Army has a pretty big ER training program. I always sort of thought that's just where I would default want to go. I used to live there. And I rotated through here, and after a month in this ER, just seeing how busy they were, how many really sick people came in there every shift, and I decided pretty quickly, if I can go there, I think I can easily be trained well and work anywhere in the world. So we're over 100,000 a year as far as volume. I was saying earlier, the amount of critical care in an average ER, and this is back a few years ago, is about 3 to 5%, meaning patients you either admit straight to the ICU or sent to the operating room. That year, our average is around 13 to 15% of the patients are considered to be critical. So for me, I just came here because it's kind of for lack of better word, down and dirty county hospital. It sees a lot of patients and a lot of patients. And I like how good the residents were here at just critical care patients in the ER, as well as managing all the other patients at the same time. Plus it's Vegas, it's not a bad place to live. You're really going to be trained well. Anywhere you go in the U.S., you're going to be trained well. The programs they're all good. I just wanted somewhere that saw a lot of patients and a lot of sick patients. I didn't really want like a rural setting.
Is there a reason you chose not to do a military residency?
Well, it is. I'm active duty military right now. So 2 spots out of our Vegas residency are Air Force, reserved for Air Force. We have a base here, Nellis Air Force Base. So I really lucked out big time. I got the best of both worlds. I'm active duty and military, but getting to do this residency here. I spend a month a year. We all do. All the residents in my program spend 1 month a year at the Air Force Base in the ER there. It's considered a community rotation. So I really kind of lucked out. I'm getting the best of both worlds. It's a military residency, but I'm getting this crazy great trauma center you're training at.
What's the lifestyle like after residency for EM doctors?
After?
Mm-hmm.
That's kind of why you do EM. You can go in, you can work in any different settings, so community hospitals, that's where most people go really. There's the big academic places if you want to do academics, if that's your thing. There's fellowship, urgent cares even, I know in Texas, urgent cares are huge. We have tons of urgent cares here in town. So it's shift work. I mean, some places do 8s, some people do 10s or 12s. The salary is great, it's competitive. A lot of people even do independent contracting where salaries get really high and you're sort of taking your own taxes out, and most of those people hire accountants and manage their own taxes and that sort of thing. But really, I mean, my attendings all are crazy happy, because we do most of the work. But the pay is good and it's shift work. Like when you're done, you're done. I mean, my attendings are all the time going on trips. They seem very happy, and you can work more or less really. If you want to make more money or just work more, you can. You pick up more shifts, so you kind of push yourself towards whatever you want to do. But you can go anywhere is what I like about it. Literally any town, anywhere, work. That part of it's great. But for the most part, I don't know many unhappy ER doctors per se that are attendings and have been doing this for a while. I'm sure they're out there. But those are the ones that are maybe burned out and are working too much.
So my next question is actually what you just mentioned about the burnout. That's kind of the one thing I hear from a lot of people who caution against EM is about the burnout, that you just see so much stuff. What do you think about that?
I think it's definitely true. My intern year, I mean, there were definitely times in that year I thought, man, I don't know, this is kind of crazy. There's all these patients. There's all these sick patients, and then there's all these patients that really don't need to be in the ER, but I still have to kind of figure out what to do with them. And I think, this is just my opinion, this is strictly my opinion, I think you either kind of come to terms with that the ER is going to be busy and full. There are going to be a lot of non-acute stuff that you have to just see in order to, weed out, get to the sick patient and help them. And then in residency, it's hard to say not to work too much because you just worked a lot. It's just the way it is. That's the only way you learn how to do it. But when you're done, I think you just got to balance things a little better. I think the people that get burned out that I've seen, they just work a lot. They work a lot of shifts, a lot of hours, crazy busy places. Maybe, and I don't know what for. Maybe to pay back their loans, make more money, or to hone their skills. But you just have to come to terms with kind of the dynamic of the ER and just really accept that. That's kind of how I look at it. And come to terms with the fact you can't control what's coming in the door. I think that's why people get burned out. And that's why I see a lot of my residents, and I get burned out some shifts with. Like, it's already crazy busy, and are you kidding me? This is coming in, and now this is here. Are you kidding me? This had just happened. Now there's a 10 car rollover. Like, really, are you joking? And you just have to kind of step back and you know what? That's at the same time, that's why you go into ER. Predictability of it. The burnout's there. I mean, I won't lie to you. There are days when I'm like, oh man, this is I want to go back to med school or do something else. There really are days like that. I'm serious. But you just kind of come to terms with it. I think it's like any other specialty. I mean,
Thank you.
During fourth year, how'd you pick which rotations to go through? So like you said you went through Las Vegas. So then how'd you choose Las Vegas, and why did you choose Las Vegas?
oh, like which away ER rotations?
Yeah.
Okay, well, for me, I came to Vegas because I found out that the Air Force had spots here for ER. And then, we have spots in San Antonio, Texas, and then in Ohio. As far, I didn't do any other civilian typical ER rotations. If I would have, I mean, I knew I wanted a county hospital setting that sees a lot of volume, so I probably would have honed my ways to places like that, which would be places like UFD, Southern California, Cook County, Chicago. There's a ton, but the theme is kind of the inner city ER setting. That's what I was looking for, just because I knew that's the kind of ER that I wanted to train in. And a lot of it's, geographically. So with residency, think about where you want to be for three to 4 years. If you know you want to be in a certain area and you're passionate about that area, I mean, go rotate there. Go rotate there, show them who you are, and you get a better chance of maybe ranking there. So use geography as a tool as well. Because you have to be somewhere for 3 to 4 years. If it's somewhere you hate, it may make residency a little worse. So I would just figure out what kind of setting you think you want to train in. I mean, some people may want to train in more of a rural setting. Like, isn't Austin? They have a program, right, in Austin? Yeah. I think they are considered a little bit more of a rural setting in terms of their emergency residency. And just if you want to be in more of a setting like that, but you may get more like continuity of care at a place like that, because they have follow-up with their primary care physicians. Just figure out where you want to be, what kind of setting you want to train in, I think would be my advice.
How competitive do you think emergency medicine is comparatively? Because I've heard some people say for STEP you need a 235, and then I've heard some people say, well, don't screw it up, don't fail, and you'll get in somewhere. So
it's definitely more competitive in the past decade than it used to be. The average board scores are just going kind of, in the past decade, they've trended higher in terms of what it takes to be competitive per se for ER. And I think that's for a lot of the reasons we alluded in terms of just, it's a great lifestyle. Yeah, I remember this conversation when I was in med school. Oh man, what do I need to get on step 1 and step 2? Yeah, I mean, it's hard to throw out a number. I mean, so many things go into each applicant. But yeah, what did you say, 230, 235?
yeah.
That's a good number to shoot for. Sure, shoot for it. If you can get higher, great. I mean, I graduated with a few people, one individual, matched at ER and got to a good program. His scores were not great. They were fine. I think he had, I hate to throw out numbers because then you're going to have this like number in your head. He had like low 200s or something on step 1. And, 220 or something on step 2. And he did fine, he matched. Here's the thing, take your number, whatever that is, and just be realistic with it and how competitive you are. If your numbers are okay, they're not through the roof, but they're not bottom, and you're looking to only apply to like these huge, crazy academic places, you might not apply, right? Yeah. Just like med school. Just like getting into med school. This is a generic answer, but just don't blow off step 2. They don't want to see you go down on step 2. So try to match or go higher. And I would say try to go 20 to 30 points higher on step 2. That's kind of what they want to see. Just 220s and up. That's what I would aim for. I don't want to think about step. I get nauseous thinking about step 1. And I remember
Everyone else in this room.
I remember your rotations at UMC the day the scores came out for all of us. And all these texts went out through all of our phones. Like, oh, the scores are out. And we're all like, oh, God. Yeah. They scared us so much. Our first class that came through this new curriculum and all this, so they scared us into studying so much that we had pretty good scores because of the scare factor or what. It worked. Yeah. Another thing about ER is, I know I mentioned scope of practice, but I knew I wanted to work with kids as well. I did not want to be a pediatrician, but some of my nursing background was pediatric ICU, so I knew I wanted to do something too that I could still work with kids, which I get to do. Let's see. I guess the amount of pathology that comes through every shift is pretty cool. You see crazy stuff obviously, but I mean, the fun part of it is every patient's sort of the undifferentiated patient. You know, they're not already worked up, so you got to figure it out. It's like playing detective a little bit, and that part of it's fun. I mean, you get stuff where we've diagnosed, you know, like Wegener's. You guys learn about that stuff, vasculitis and all that stuff. Of course, you get your big, bad, scary diseases, your AAAs, your, of course, heart attacks and strokes, all that stuff. But more so than anything, the bread and butter stuff, that stuff becomes easy. It's just the weird stuff that comes in with, the right side of my body's numb and that kind of stuff. Which usually they're just anxious. But you kind of play detective. That's how we look at it.
How often do you work night shifts and weekends? Is that just regular, or do you get to kind of choose, I want to work day shifts mostly?
Oh, that's a great question, actually. Yeah, so if you go into ER, your job it never closes. So accept the fact that you're going to spend maybe a 30-year career working nights and weekends and holidays. So kind of go ahead and accept that and just take it to heart. We flip between, you do a couple of weeks on nights, a couple on days. And it varies. We have a good scheduler. Our chiefs are good, so if you request time off, you usually get it. If you need certain weekends off, it's not that bad, to be honest. But you do work nights. I mean, that's the beast of being ER doc. When you get on the outside, depending on where you go and you finish residency, I mean, there are some attendings who they just want to work nights. I hope that I end up at a place like that, because the older I get, the harder nights get, just because it meshes with your sleep. But I guess the short answer is yeah, you're going to work nights, you're going to work some weekends, holidays. Yeah.
What did you think of UMC's residency?
Oh, in El Paso?
Yeah.
I think it's great. I think it's a good residency. The only reason I didn't apply there is because I knew I pretty much, being a military resident or a military student, I knew there was a pretty small chance that I would stay there, so I didn't want to take an interview spot. I think it's great. I think the ERA was pretty new when I was there. It's huge. I liked all the attendings, the ones I worked with anyway. They have good volume. They see trauma. They have good pathology. So I think it's a great residency. I think mine is much better. Don't tell Dr. Greer I said that. Please. No, it's a great place. I had a good time at Paul Foster. I never intended on moving to El Paso, but I was pleasantly surprised with how much I liked our school, and I really feel like you guys are in a good place. I came out of there as prepared as I could have been.
So you mentioned in the residency training program that you do like an ICU month and then you do ER months. I know here that they also take you out to like wilderness training. Do they do that there? Or is that common?
Yeah, there's wilderness medicine here. Dr. Horvath, one of our attendings, heads up wilderness medicine. So yeah, you can go out and do wilderness stuff. Some people have done that as an elective, an entire month doing it. Other people just do EMS. You can do tactical medicine stuff. Really, the sky's the limit as far as that goes. Yeah, there's a lot of that here. It's a huge hiking community. We have Mount Charleston, and then we're down the road from Zion, and up the road from the Grand Canyon. So that's actually a pretty good community here. Wilderness medicine, anyway. Tactical medicine is really cool. It's something I really didn't know existed before I got here. My program director actually works with SWAT and even FBI. He goes out and does this basically tactical medicine where you're out on scene with those kind of guys doing SWAT. Obviously, if they get hurt, shot, or whatever, you're kind of the guy. You're the on-scene medical command, which is pretty cool. I didn't know that really existed until I got here. But it's specific just to emergency medicine, as far as I know. What else do you guys want to know, I guess, about residency or how many see a show of hands, how many people are pretty die hard think you're going to do ER? Okay.
Yep.
Let me ask you guys, I don't know, just shout out why. Why do you want to do ER?
Excitement.
Unpredictable. Should work.
Yeah.
Career
Lifestyle.
mobility.
Yeah. Can go anywhere.
Procedures.
Yep. No, that's exactly kind of, you hit the nail on the head with all those. I mean, that's exactly why people do ER. What else are you guys considering like that are, I mean, what's your number 2?
Internal.
Yeah.
Death by rounds?
Yeah. Death by rounds. Did you ever think about trauma surgery?
Yeah, before I had a family. No, God, a long time ago when I first thought I'm going to try to go to med school, that's actually sort of what I wanted to do. Some of that stemmed from, because I was a nurse on the outside first, actually back east at a place called Wake Forest, Bowman Gray, North Carolina. I joined the Air Force and they took me to Texas, and then of course from there I did ICU and I deployed to Iraq, 05, 06, 07. Basically we were in a field 10 hospital. And it was a lot of trauma, obviously, and I kind of set out to think I want to be a trauma surgeon. So surgery was high on my list for a long time. I almost did surgery. I was married and had a child and stuff in med school. I had support. My wife said, if that's what you want to do that, but please God, find something else you want to do. So at the end of the day, I already through surgery, I was still thinking I want to do this, and I just had to sit down and kind of be honest with what lifestyle I wanted and kind of what I wanted to get out of this. And honestly, I had the advantage. My best friend in the world is a surgeon. He went through a pretty hard residency and a fellowship, and we had a bunch of talks, and I remember this one specific conversation. He said, okay, Jamie, is there anything else in medicine that you can do that'll make you happy? I said, well, yeah, I think so, sure. He said, okay, you're done. Do not do surgery. And that's what I've gotten from a lot of surgeons, is the fact that he was one of those people that's the only thing in the world that was going to make him happy, was doing surgery, being in the OR, being that guy. And I think a lot of people go into surgery because it's cool, right? It's surgery. You're a person taking out the diseased organ or whatever. It's cool. There's a lot more to it than just being in the OR doing glamorous things, and I think people go into it for the wrong reasons that end up unhappy. So that's kind of how I chose ER. For me, it was the perfect fit because we do, it's crazy procedures for us where I'm putting in chest tubes and lines all the time. We've done thoracotomies, we've done pericarditis, and that's enough fixed for me to get my procedure kind of down and dirty fix, and we do it on a routine basis. I forgot your original question. Did that answer it?
Yeah, you got it.
You got it. Yeah, but I thought hard. It was tough. It was like, man, do I do surgery? But I'm not. One of my classmates, Grace E., her brother may still be a surgery resident there. I'm not sure. He's like a 4th or 5th year now. But she was wanted to do surgery, and she tried not to. Like, she rotated and everything else, tried to find something else she wanted to do, and at the end of the day, there was nothing else that made her happy. So she's a surgery resident now. And she's happy, but she did it for the right reason. That really makes her happy.
Can you talk about family balance as far as being a resident and trying to do that?
Family, what was the question?
Family balance while being a resident?
Oh man, sure. Well, I still work on that every day. I'm finally getting better after 4 years of med school and 3 years of residency. I'm sort of figuring it out a little bit, which is good. Just some months are tough, like the IC months and the really long, kind of grueling months. It's just kind of hard. My advice is on those months when you're home, just be focused and be present and be home. That's what my wife always said, which there were so many times when you're home but you're not. You're still, your mind is there and you're distant. And kind of once I figured out, when I'm home, just be home. Just really be present on the hard months. That made that much easier. If you have family, just listen to them, realize that while you're off at the hospital, seeing all this crazy stuff and working all the crazy hours, they're still there. They're still, at home missing you and wondering, what's going on in your head. So just talk to them, and don't shut them out, and just be present, I guess. That's really a great question, actually. Like, that's something people don't think about. But you see, so do you guys know what the divorce rate in medicine is?
Very, very high.
Yeah, and there's a reason. It's because people, I think, check out. They just, they're in that world and they just check out, and their mind is at the hospital all the time. You become roommates and you quit talking, and it's a classic story. You see it all the time. But be present and keep talking, and just sort of be brutally honest with each other. That's really the best thing. My wife and I are pretty brutally honest. She gets feelings hurt sometimes, but it works because we kind of always know what's going on. We're not balling everything up. But the one-liner is just be present when you're there with them. What else? Let's see.
How about moonlighting?
Oh yeah. Well, I can't because the military they don't allow the residents to moonlight. But some of my colleagues have started as third years, and it's a great experience. I could if they would let me, because you're honestly, as a third year, you start thinking, all right, I got this. I've seen a lot, and then from the people I've touched in the moonlight, you're out on your own, and it's on you. It's like, oh man, this is kind of scary at first, because you're the attending, you're the person that kind of the ball stops with. But if you go to a residency that'll let you do it, I would encourage it. I would do it. The experience is great. They say your first year out, the learning curve is so high because you're out on your own. You're figuring out how you're going to do it yourself. And plus, the money's good, right? You can kind of pay real doctor money. That's nice. So do it if you can. I would if I could. The Air Force won't let me. Are any of you folks military, HPSP? Or what branch?
Air Force.
Army.
Okay. Where are you guys looking to go? Well,
Probably back to San Antonio. That's where I'm
Tennessee?
from. Yeah.
Okay. Well, I guess just real briefly, there's a lot of specific, really cool jobs in the military. If you are military, or if you're ever thinking about military, that if you're an ER doctor, you get to do. Next month, so I'm going to go down to Hurlburt Field, Florida, which is where the Special Operations, Special Forces folks for the Air Force hang out, and apply for a job that I'm going to try to do when I'm done with residency, where you're basically part of a sort of a forward operating team with the Special Forces community. So it's a lot of extra training with them, and I would spend half my time doing that and the rest of my time in ER working shifts. Right now they have a spot at University of Alabama, Birmingham. They may stand up a spot here, so it's kind of cool. I'm hoping if I get the position, so I'll be doing kind of Special Forces medicine in addition to ER, which is just really freaking cool. It's a lot of fun field military training, so that's just something very specific to military medicine and the ER that you can do.
How many Air Force residencies did you apply for during your 4th year?
All of them, all the active duty. So here, San Antonio, Wright-Patterson, that's where the active duty spots are. But I applied to about 20 civilian spots, and just in case you can get the civilian deferred, they can defer you out to a civilian residency. So I applied to about 20 or 24, and I interviewed at a good 12, maybe 14. But once I military matched in December, I canceled kind of all those spots and interviews because then I'm done. But I didn't take a chance. I wanted to make sure I was in an ER residency, either active duty military or civilian. So, and as far as the interviews I did civilian, I interviewed all over. I applied to East Coast to West Coast. I guess the biggest piece of advice I would have for you guys is just kind of shadow and get around ER docs. Talk to a lot of different ones. Talk to residents. Just get a feel for why they did it. What they like, what they don't like. And I sort of sat down at the end of the day and made a race board, sort of pros and cons, what I was looking for. And it's kind of dorky, I guess, but the end of the day, it works for me. I love ER. I mean, I wouldn't do anything else. There are days where I'm like, man, this is hard. But I couldn't do anything else. If I did anything else in medicine, I would have to just, I don't know, I'd go work at Starbucks or something. It's a good fit. The personalities in ER are great, I guess, too. It's a very eclectic, diverse group of people. I mean, you get your every kind of person you could think of in the emergency room. A lot of deep personalities, but at the same time, we're all sort of the same in the sense that, you're sort of like the doer. You don't want to sit around and talk about it for hours. You want to just get in there and do something. Where are you guys from? Just shout out stuff. You guys all from Texas? Probably not, right?
Texas.
It's Dallas people.
Connecticut.
El Paso? Is Dr. Veal still doing anatomy?
He left this past year, actually.
He what?
He left this past year.
Where'd he go?
New Mexico.
Oklahoma, yeah.
Huh? To a med school?
Yeah, he's gonna teach there.
He's the department head of anatomy.
Really? Oh wow, well good for him. I used to play golf with him. Yeah. How about Dr. Osborne? Is he still there?
Dr. Osborne left last year, too.
Man. What about, let's see, who does biochemistry?
Dr. Hogg?
Who?
Dr. Hogg?
Yeah, he's still there?
Yep.
Okay, still got him. That's good. I like him. Do they still do, well, Alex is still in the office, right? I was supposed to see him?
Yes.
Yep.
Tell him I said hi to somebody, please.
Okay.
What about, let's see, who does histology, pathology?
Dr. Farr?
Far.
Yeah,
Kurt Farr.
are both of them still there?
Yes.
Yeah.
Dr. Quay?
Genetics or genetics?
Yeah.
Definitely.
Dr. Quay.
Has she cooked for you guys yet?
No.
Chili cook-off.
Yeah, for chili cook-off she did.
You did? Make her make French food. She makes French food, right?
Yeah.
It's occasional.
Yeah, she's pretty amazing. I liked all the faculty there. I thought, man, there was such a great bunch of faculty when I was there.
What college were you when you were here?
Blue? When I was there, it's so funny. It's like when I was there, there was only like 4 colleges.
There's still
Yeah, there's still only 4.
Only 4.
But they just keep on adding more people.
How about Dr. Woods?
Oh, yeah.
Dr. Woods is here.
I love Dr. Woods.
Everybody was
He's like the best father figure.
Ever.
His voice is so smooth. You guys still do workplace scenarios on Friday?
Yes.
Yes.
Just did them.
Do you still do Spanish?
Yes.
Yeah, I just use an interpreter now. Honestly, I came out though, knowing more than Spanish than I thought. I was very just white and not speaking Spanish. But I came out knowing a lot more than I thought I would, I guess. I'll still need an interpreter.
Did anybody mentor you here that maybe we could get in contact with them?
Good question.
Did they mentor me for what now?
For ER, did you have an ER mentor that you'd recommend?
I talked with Dr. Greer some. She wasn't really a mentor, I guess. I talked to the doctor, Parka?
Parsa.
Say it again?
Parsa.
Yeah, I guess.
He
I had
says
to-
hi. I had him for work case today.
Yeah, I guess he would be, more of a mentor than anyone. He's a very soft-spoken, nice guy. Yeah, I guess if I had to pick one, it would be him. But Dr. Greer's good. He's good. Is Dr. Nelson still in the ER?
He just retired.
He just retired, but he's still really involved.
Yeah, no, that guy's been around forever. He's a wealth of information. That sounded bad. I mean he's old. But you know what I mean. He's been around emergency medicine a long time. He's a really good guy to talk to because he's been around since emergency medicine residency. We're just kind of getting going, I believe. Anybody over there would be good, but I remember Dr. Greer and Dr. Parka, I'm saying his name wrong. Yeah, those would be my 2 recommendations. They're both really good. Well, make sure you give them my contact information. If you guys ever have questions about, anything, ER, life in general, or residency, feel free to email or call. Not just about this residency, but any residency. Obviously, I love my residency. If you guys have specific questions about this when it comes time to apply, let me know.
Okay. Thank you so much for taking the time out to come talk to us. We really appreciate it. I enjoyed this. I hope you guys did too.
Yeah, thank you.
Yeah, thanks, guys. I appreciate you talking to me. It's you guys are all going to do fine. You're going to do great. Just keep doing what you're doing. Tell everyone there I said hi and that still remembers me.
We will.
The picture's in that case somewhere.
Yeah.
Find it.
We will.
Tell him he's in a
All right,
renal
thanks so
car.
much,
He
guys.
has like a bottle of tequila and
Yeah, he's famous.
Oh, apparently you're in one of our renal PowerPoints with a bottle of tequila.
Oh, yeah.
Oh, yeah. Right?
Yeah.
Yeah.
Dr. Jansen.
I'm going to defer on if that was actually tequila. Yeah, we worked hard, played hard.
All right.
All right, guys.
Bye. Thank you, Dr. Hayes.
Bye. Take care.
You too.